Mr. Cornelius?
Yes.
Hi, I'm Savannah Adams. I'm a PA student at the University of the Cumberlands. Excuse me for just 1 second while I wash my hands. Okay, could you please just tell me your name
Houston Cornelius.
and your date of birth?
March 23rd, 2005.
Okay, I'm just going to look at your hospital case there. Okay, let's go. Okay, today we're going to be doing the skin and HENT exam. So first, have you noticed any changes in your skin, hair, or nails? Any type of lumps or rashes or moles that look kind of weird or anything like that? Okay. I see that you have some eczema here, but is the medication controlling that well and everything
Yes.
is looking good? Okay, so to do the full skin exam, I'm just going to gown you right quick. You can just continue to sit up there, and I'll just kind of wrap this over you. Yeah. Okay. Okay, and it's very important to always do skin exams on yourself. So just like, if you notice any type of strange rash or any type of moles that look any different, like maybe they're, instead of being round, they're kind of jagged on the edge, or they're black instead of brown, or they itch or bleed or anything like that, it's very important to always get those checked out. It's always very important to do the self-exam. So you would just want to always, kind of feel in your head, make sure there's no lumps or anything on your skin or in your face or on your extremities, okay?
So now what I want to ask you about is any kind of color changes to your skin. So we want to look at any hyperpigmentation, or if it's like, has it turned brown, or has it got any white spots anywhere, or if you have anything like jaundice where your skin is yellowing in different spots or anything along those lines. So do you have any skin color changes at this time?
No.
Have you noticed any kind of difference with your skin turning white to hot or cold or anything along those lines?
No.
Or any increased redness anywhere? All right.
Alright, so next what we're going to do is I'm just going to feel your skin. So what I'm going to feel for is just right here, any temperature. It doesn't feel too hot, too cold. The moisture feels good. It's not too dry, not too oily or sweaty. The texture also feels good, not dry, not rough, and not too smooth. It all looks good. So what I'm going to do now is I'm just going to turn your hand over. I'm going to pull up some skin like that and have it fall down, which is just testing the trigger and mobility. And it doesn't look like you're dehydrated. If it was, it would have a kind of a longer time higher in the air. So that looks good. I don't see any lesions, but if I did, I would palpate them.
All right, now I need you to stick out your hands like this. And what I'm doing is I'm going to check for capillary refill. Capillary refill is found by me pressing on your nail here, and it should be less than 2 seconds. So you see how it turns white? I'm looking for it to turn back pink in less than 2 seconds, which it does, so that's good. I'm also noting on your nails any pitting lines or any deviations going on, which you look good right now. I'm also looking for a angle of the nail to be less than 180, so that way we don't see any kind of disease process like COPD going on, which you look good right now, okay? Now we're going to do a head inspection on you. So the first thing I want to do is ask about any kind of problems that you've had with your head. Have you had any kind of bumps or anything like that, or any pain, any kind of lesions up there on top of your head? Okay. Do you have a hairpiece in?
No.
I would have you remove it right now. Then I'm going to feel in your hair real quick, all right?
Okay.
Whenever I'm feeling in your hair, what I'm feeling for is the texture and the distribution, and I'm making sure that everything feels good and that you don't have any balding spots. While I'm here, I'm also going to be feeling on your scalp, and what I'm feeling for is any nevi or any kind of lesions or bumps that you might have that you might not have noticed. Then I'm feeling to your skull, and I'm feeling on the suture lines to make sure that they're intact, and making sure that there's no deviations or divots in there as we go along. Does everything feel okay?
Uh-huh.
All right. I'm now going to fill in your face too, okay?
Okay.
So whenever I fill in your face here, I'm just making sure that you can feel everything that I'm doing. Okay? Can you smile at me, please? All right, I've got asymmetrical movement, and you've got a normal facial expression going. Now, have you noticed any kind of nervous tics or anything in your face where it's just moved on its own? No? Okay.
A Snellen chart is unavailable right now, but normally we would check the visual acuity 20 feet from the chart. Determines the smallest line of print they can identify more than half the letters. This is expressed in 2 numbers. Next, we're going to check the near vision with a handheld card or any available print held 14 inches away. Identifies if the patient needs reading glasses. Next, we're going to perform a visual field by confrontation. We have the patient look into their eyes. Patient's hands 2 feet apart, lateral to ears, slowly moves wiggling fingers towards the line of gaze until patient identifies them, normally sees at the same time. Next, what we're going to do is inspect position of and alignment of eyes. Stands in front of patient, surveys position and alignment. Inspect eyebrows, note quality, quantity, distribution, any scaliness of underlying skin. Inspect eyelids, note width of palpebral fissures, edema, color lesions, condition of eyelashes. Inspect lacrimal apparatus, cheeks, checks regions of lacrimal gland and sac. Inspects conjunctiva and sclera. Asks patients to look up. Depress both eyelids with thumb. Inspect color and vascular pattern against sclera. Look to each side and down.
Now we're going to inspect the cornea and the lens for opacities using oblique lighting. Next, we'll be inspecting the iris, noting markings should be clearly defined. Next, we'll inspect the pupils and determine if they have an adequate size, shape, and symmetry. Next, we'll be testing reactions of pupils to light. We will ask the patient to look into the distance, darken the room, and use a bright light. We will be determining if there is a direct reaction of pupillary constriction and a consensual reaction, which is constriction in the opposite eye. Okay, now we'll be testing the near reaction. We will be holding our finger about 10 centimeters from the eye and look alternately at it and into the distance. Watch for constriction with near effort. Next, we will be testing extraocular movements. Make a wide H in the air. Lead the gaze to the extreme right, right and upward, down on the right, without pausing in the middle, to extreme left, left and upward, down on the left. If needed, we could hold the patient's head in proper position. Next, we will be testing convergence. The patient will follow the finger toward the bridge of the nose. The eyes will follow the object or the finger 5 to 8 centimeters from the nose. Next, we will be examining the upper palpebral conjunctiva. The patient will look down, grasp the eyelashes, and pull down and forward. We will place an applicator 1 centimeter above the lid margin, push down on the stick, and raise the edge of the lid. We will not press on the eyeball and secure the lashes against the eyebrow. Okay, now we will be demonstrating the use of the ophthalmoscope. We will move the lens disc to a large round beam and set the disc to 0 diopters and make sure that the room is darkened. We will keep the finger on the edge of the disc to make sure we can focus the lens. We will be holding the scope in our right hand to examine the right eye and left hand to examine the left eye. We will hold firmly against the medial aspect of the bony orbit. We will have the patient look at a point on the wall. We will stand 15 inches away and 15 degrees laterally. We will shine the beam on the pupil and look for the red reflex. We will place our thumb on the other hand across the patient's eyebrow. We will keep the beam focused on the red reflex and move in on a 15-degree angle toward the pupil. We will follow a blood vessel centrally. Next, we will bring the disc into focus by adjusting the lens. The optic disc will be inspected as well as the retina and vessels. We will inspect the fovea and the surrounding macula.
Okay, you can look at me now. Perfect. All right, and now we're going to do it on your other eye, okay?
Okay.
When inspecting the ears, we are first going to inspect the auricle and the meatus. We're going to note deformities, lumps, and skin lesions. Next, we're going to inspect the ear canal using the largest speculum. We're going to straighten the ear canal by grabbing the ear firmly, pulling upward, backward, slightly away, and hold handle between thumb and finger. Brace hand against patient's face to avoid unexpected movements. Direct speculum towards down and forward through hairs. Note discharge, foreign bodies, swelling, and redness. Next, we're going to inspect the tympanic membrane. Note color, contour, and cone of light. Identify the handle and short process of the malleus.
We will now perform a whisper test. Occluding one ear, we will stand 1 to 2 feet away and exhale and whisper a combination of 3 numbers or letters using a different combination on other side. Next, we will check lateralization using the Weber test. Using a tuner, we set it into light vibration and place it on the top of the head and ask patient where they hear it.
Did you hear it
In
on
one
both sides?
Yes.
or both are normally heard in midline or equally in both. Patients with normal hearing may lateralize. Next, we will check for air and bone conduction using the Rhine test. We will set the tuner into light vibration. We will place it on the mastoid bone and ask when the patient is able to no longer hear it.
Can no longer hear you.
Whenever they can no longer hear it, we move it over close to the ear canal and we assert whether or not they can hear the sound again. And we would repeat on the other side. This proves for air conduction is greater than bone conduction.
First, we will inspect the anterior and inferior surfaces of the nose. We will note any asymmetry or deformities. We will exert pressure on the tip of the nose to widen the nostrils, tilt the head, and insert the speculum, avoiding the septum. Next, we will test for nasal obstruction. We will press on each side of the nose and ask the patient to breathe in.
And then the other side.
Okay, next we will inspect the inside of the nose, avoiding contact with the sensitive nasal septum. We will note the color and if there is any swelling. Next, we will palpate the frontal and maxillary sinuses. We will press the frontal sinuses from under the brows and press on the maxillary sinuses for tenderness. Okay. Now we'll be doing the mouth and pharynx exam. First, we will inspect the lips, observing color, moisture, looking for any lumps or ulcers, cracking, or scaliness. Now we'll be inspecting the oral mucosa. If the patient had dentures, we would have them remove them. We will palpate any lesions and use a light and tongue blade to note the color, look for any ulcers, white patches, or nodules. We would also inspect the gums. We're going to look for their color, which is normally pink, and make sure that their margins are clear. We will look for any swelling or ulcerations. Next, we would inspect the teeth. We would note if there was any missing teeth, discolored teeth, any teeth that were misshapen, or abnormally positioned teeth. We would check for looseness with the thumb or index finger. Next, we would inspect the roof of the mouth. We would note the color and architecture of the hard palate. Next, we would inspect the tongue and floor of the mouth. We would have the patient protrude the tongue and note the color and texture and make sure that the tongue is symmetrical. An asymmetrical tongue can be indicative of abnormalities. The pharynx. We have the patient open their mouth without protruding their tongue and press the tongue blade down at midpoint of tongue if needed. We will ask the patient to say "ah" or "yawn" We will notice the rise of the soft palate. We will note the color symmetry. Notice if there's any exudates, swelling, ulcerations, or enlargement of the tonsils.
Next, we're going to palpate lymph nodes in sequence, note size, shape, discrete or matted, mobility, consistency, and tenderness. First is preauricle, in front of the ear. Next is posterior auricle, mastoid region. Next is occipital, base of skull. Next is tonsillar, angle of mandible. Next is submandibular, midway between the angle and tip of mandible. Next is submental, midline a few centimeters behind tip of mandible. Next is superficial cervical, superficial to sternocleidomastoid muscle. Posterior cervical, anterior edge of trapezius. Deep cervical chain, often hook thumb and finger around either side of sternocleidomastoid muscle. And finally, supraclavicular, above the clavicles, in between the clavicle and the sternocleidomastoid muscle.
Okay, now we are going to perform an exam of the thyroid. We're going to inspect and palpate the trachea first. We are going to identify the thyroid, crackly cartilages, and the trachea. We will note any deviation of the trachea from the midline position. We'll place one finger along one side and note the space between it and the sternocleidomastoid muscle, which should be symmetric, and then we will do that on the other side as well. Next, we will palpate the thyroid gland from the posterior approach. We will have the patient flex their neck slightly forward to relax the sternocleidomastoid muscles. We will check the isthmus by placing our fingers of both hands on the neck so that the index fingers are just below the cricoid. We will have the patient swallow and feel for the isthmus rising up under the finger pads. Next, we will palpate the thyroid gland. We will displace the trachea to the right with the left hand, palpate laterally for the right lobe in the space between the trachea and the sternocleidomastoid, and then repeat on the left side. Now we're going to be moving on to the thorax and lung exam. So for a man, I will gown them so that they can have their chest fully exposed to do the exam. For a woman, we would have the anterior chest fully covered to examine the posterior back, and then to examine the anterior, we would have one side covered to examine the other side, and then vice versa. So first I'm just going to be just looking at you to see if I see any cyanosis. I'm going to be listening for any audible wheezing or anything like that, any type of noise I can hear that you're having trouble breathing. And I'm also looking around the neck to see if you're having to use your accessory muscles to breathe. Okay, now we're going to be performing an exam of the posterior chest. First, we will instruct the patient to assume the sitting position and ask the patient to fold their arms across their chest and rest their hands on the opposite shoulder. We will inspect from midline positions behind the patient looking for symmetry. Next, we will inspect the shape of the chest for increased AP diameter, which could be evidence of possible COPD. Next, we'll be moving on to palpation. We will palpate any painful areas, any lesions, or any obvious abnormalities. Next, we will palpate for posterior chest expansion. We'll place thumbs level with the 10th ribs, position the hands parallel to lateral rib cage, raise a loose fold of skin between the thumbs, and ask the patient to inhale deeply and feel for range and symmetry. Next, we will palpate for tactile fremitus. We'll place the ulnar surfaces of our hands to compare symmetric areas of the lungs, asking the patients to repeat 99.
99,
And again.
99,
And again.
99,
And again.
99.
Fremitus is more prominent in the interscapular area. Next, we will move on to percussion. We will percuss the posterior chest. We will stand to the side of the patient, percuss twice in each location, and compare the two symmetrical sides in a ladder-like pattern.
Okay.
Next, we will percuss for diaphragmatic excursion. We will identify the level of dullness during quiet respirations and determine the distance between the dullness on full inspiration and expiration.
You have a big inhale for me?
Okay. Diaphragmatic excursion is normally 3 to 5.5 centimeters. Next, we'll be moving on to auscultation. We will position the patient with arms folded across the chest and hands resting on opposite shoulders if they are not already. We will verbalize and instruct the patient to breathe deeply through their open mouth. And we will also demonstrate the correct method of listening to breath sounds. We will use a ladder pattern to compare sides using the diaphragm of the stethoscope. One full breath needs to be listened to in each location.
Big breath. And again. And again. Last one on both sides. Good work.
Next, we'll be demonstrating the exam of the anterior chest. We will instruct the patient to assume a supine position with arms slightly abducted. Next, we will be inspecting the anterior chest. We'll observe the shape and movement of the chest wall and see if there's any accessory muscle retractions. Next, we will be palpating. We will verbalize and palpate tender areas if indicated, asking for any tenderness. Next, we will palpate any noted abnormalities. Now we will assess the anterior chest expansion. We will place the thumbs along the costal margins with hands on the lateral ribcage. We will raise the skin fold between the thumbs, ask the patient to inhale deeply and observe the extent and symmetry of movement. Next, we will perform tactile fremitus of anterior chest. We'll place the ulnar surface of our hands to compare symmetric areas of the lungs, asking the patient to repeat 99.
Say 99.
99. 99. 99.
Next, we will move on to percussion. We will percuss the anterior chest by standing to the side, comparing the two symmetrical sides in a ladder-like pattern. The heart normally produces an area of dullness left to the sternal border. Next, we will auscultate. We will instruct the patient to breathe deeply through an open mouth.
Breathe in through your mouth.
We will demonstrate the correct method of listening to breath sounds using a ladder-like pattern to compare sides using the diaphragm of the stethoscope. We will listen to at least one full breath in each location.
Next, we are going to assess transmitted voice sounds. First, we are going to assess egophony. We are going to ask the patient to say E. E. This will sound normal when it is heard as a long, muffled E. It'll sound abnormal when it has a nasal quality or an A sound to it. This could indicate possible lobar consolidation from pneumonia.
Okay, whenever you feel my stethoscope against your back, just say E, okay?
Okay.
E.
E, E, E.
Okay.
Next, we are going to do whispered pectrility. We're going to ask the patient to whisper 99. Normally, it's going to be faint and indistinct. Abnormally will sound loud and clear.
Okay, whenever you feel my stethoscope, just whisper 99, okay? Okay.
Finally, we are going to assess bronchophony. Bronchophony is when the patient says 99. Normally, it will sound muffled and distinct. Abnormally will be loud, clear.
Okay, when you feel it, my stethoscope, just say 99, okay?
99, 99, 99, 99.
Okay, good.
Discuss some normal breath sounds. So first we're going to be looking at vesicular. Vesicular is found all over the lungs. It's soft and it's low, and the inspiration actually lasts longer than the expiration, and the sound fades off about a third of the way through the expiration. Next, we want to talk about bronchovesicular sounds. Now they're best heard on the anterior chest between the first and the second intercostal space between the scapulas. It's about an intermediate intensity and it's an intermediate pitch. And both the inspiration and expiration last the same amount of time, but there is a silent interval in between. Next, we want to talk about the tracheal sounds. The tracheal sounds are best heard over top of the neck. They're going to be loud and harsh, and they're going to be very high pitched. And the inspiration and expiration are going to be both equal.
So I'm just going to explain to you what adventitious breath sounds are like, okay?
Okay.
So first we have rails or crackles. Rails or crackles are when there's fluid in the lung. So it's going to sound discontinuous, intermittent, non-musical, and pretty brief. And some diseases that are associated with that are pneumonia, CHF, really anything that has fluid. There's two types of crackles or rails, fine and coarse. Fine are soft and high-pitched, and coarse are low and loud. So the next type of adventitious breath sound are wheezes. So wheezes are high-pitched, continuous, musical, and prolonged. It kind of has a harsher, hissing, thrill kind of sound to it. And that's due to a narrowing of the airways. So asthma, for example, COPD, any of those types of diseases. And finally, the last type of adventitious breath sound are rhonchi. And rhonchi are just low-pitched. They're also continuous, prolonged, and it has more of a snoring quality. And that's due to secretions in your larger airways. Next, we're going to locate the findings on the chest. Anteriorly, we're going to locate the sternal angle. We're going to go to the suprasternal notch and go 5 centimeters down to the horizontal ridge joining the manubrium and the body of the sternum. We are then going to move laterally to the second rib and then walk down to the second inner space. Then posteriorly, we are going to locate the 12th rib. We're going to press in and up against the lower border of the 12th rib, then walk up interspaces. We are going to locate the inferior tip of the scapula. This usually lies at the level of the 4th rib or interspace. T7 to T8 is a landmark for thoracentesis. Finally, we are going to locate the spinous process of C7. Have the patient flex forward with their head, and the most prominent vertebrae should be C7. From C7, walk down to T12. Next, we are going to describe the lines of the chest. First is the mid-sternal line. Next are the mid-clavicular lines, which drop vertically from midpoint of the clavicle. Next is the anterior axillary line, which drops vertically from anterior axillary folds, the muscle mass that borders the axilla. Next is the mid-axillary line, which drops vertically from apex of axilla. Next is posterior axillary line, which drops vertically from posterior axillary folds. Then we have the vertebral line, which overlies the spine's process. And finally, the scapular lines, which drops from the inferior angle of the scapula.
Okay, now we're just going to locate some chest findings. First, we're going to locate the supraclavicular area, which is above the clavicles. Next, the infraclavicular area, which is below the clavicles. Next, we're going to go posteriorly and check the interscapular area, which is between the scapulae. Next, the infrascapular area, which is below the scapulae. Next, we're going to look at the bases of the lungs, which are the lowermost portions of the lungs. And then we will check the bifurcation of the trachea into the mainstream bronchi, which is anteriorly at the sternal angle and posteriorly at the T4 process.
So for the cardiovascular exam, we're going to stand on the patient's right side, place the patient in the supine position, and having the head of the bed elevated to 30 degrees. We're going to examine the carotids. We're going to inspect the neck for carotid pulsation, which may be visible medially to the sternocleidomastoid muscle. Then we will palpate the carotids by placing index and middle finger in lower third of neck, just inside medial border of a relaxed sternocleidomastoid muscle at the level of the cricoid. We're going to avoid the carotid sinus found at the level of the top third of thyroid cartilage. Evaluate for carotid bruits by having patient hold their breath while auscultating with diaphragm near upper end of thyroid cartilage, below angle of the jaw where carotids bifurcate.
Okay, whenever you feel my diaphragm against your neck, you can hold your breath. So you can breathe. Okay. Now hold your breath. Okay, good. Now we're going to be inspecting the chest wall. First, we will locate the mid-sternal, mid-clavicular, and axillary lines. Next, we will inspect the anterior chest for location of the PMI. The possible use of tangential lining may make this PMI more visible. Next, we're going to be palpating the chest wall for thrills and heaves in the aortic, pulmonic, left sternal border, and apical areas. The point of maximal impulse, which we talked about earlier, is a brief early pulsation in the left ventricle touching the chest wall. To locate the PMI, we will have the patient in the supine position and palpate with the palmar surfaces of several fingers, then use the fingertip of one finger for finer assessment. The PMI's vertical location is usually at the fifth intercostal space, and the horizontal distance is about 9 centimeters from the mid-sternal line. Now we'll be auscultating the heart using the diaphragm and the bell. First, we will use the diaphragm firmly against the chest for high-pitched sounds. We'll be auscultating the aortic area, which is the second right intercostal space. We'll be auscultating the pulmonic area, which is the second left intercostal space, the tricuspid area, which is the left lower sternal border, and the mitral area, which is at the apex. We will then use the bell and place it lightly against the chest for lower pitch sounds. We will be listening to the aortic, pulmonic, tricuspid, and mitral areas once again. Next, we will have the patient turn slightly on their side in the left lateral decubitus position to auscultate with the bell. We will listen at the apex for possible low-pitched sounds of mitral stenosis. Next, we will have the patient sit up and move forward after a full exhalation.
I'm just going to have you lean forward, and I'm going to have you exhale.
We will also take with the diaphragm along the left sternal border to evaluate for aortic murmurs. I'm going to have the patient lie supine so I can examine some peripheral pulses. Okay, first we have the brachial pulse, which is just medial to the biceps tendon. on the other side. Okay, now we have the radial pulse, which is lateral on the flexor surface. And then we have the ulnar pulse, which is medial on the flexor surface.
Next, we're going to evaluate for the femoral pulse, which is found just below the inguinal ligament. This is going to feel like a little bit of pressure, okay? Then we'll be looking for the popliteal pulse. We're going to bend the knee slightly, please. This is going to be medial behind the knee. Good. Good.
And finally, I'm going to do two. I'm just going to take your shoe off. Is that okay?
I'll take it off.
Okay.
And I'll take off my sock.
Thank you. So the next one we're going to do is the dorsalis pedis, which is just lateral to the extensor tendon. And then we are going to do medially the posterior tibialis, which is just beneath that medial medial. And I would repeat it on the other side.
Okay.
Well, that concludes our examinations for today. Do you have any questions?
Nope.
Well, thanks for coming in. If you have any questions, call the office, okay?